All right. Can you guys still see my screen, right?
Yeah.
So let's start off with some ground rules here. So this is the most important. This is interactive, right? I have cameras on. That's more just to make sure people are interactive. But sometimes people are in weird spots. That's okay. So if you can't turn your camera on, it's okay. As long as you're participating in interactive, that's the biggest point. And really, the reason for that is that some of this is review for you guys, and some of this may be some things you forgot. So I don't want to go too fast or too slow. I want to make sure that we're kind of giving you the information. It's information that's going to be valuable to you. Nothing worse than sitting through 3 hours of me just saying stuff you already know. So if it's interactive, then we can sort of speed up, slow down as we go through the material, answer questions, those kinds of things. So please be interactive. I don't want to sit here and talk for 3 hours or 2.5 hours or anything. So why are we doing this class? I think probably all of you know sort of the background to this. Obviously, Lifeline has been in an interesting situation because we've had paramedics working in the hospital, and we've finally gotten to the point where the hospital recognizes that your scope of practice. So we have fought long and hard. I wouldn't even say fought. It's more just going through the process, because everybody's supported this. But going through the process of really recognizing your scope of practice, defining your scope of practice in the hospital. And so that scope of practice, is most of it's all just the training that you've had through your paramedic school. So there's not a whole lot of extra stuff that we have to do on Lifeline to prepare you, right? But there are a few things that we wanted to kind of go beyond the typical Maryland state protocols and scope of practice. And hold on a second. Go beyond the normal scope of practice, and what that means is we got to provide some training. And so we're not going beyond the scope of practice in a lot of areas or a lot of ways. Really, if you look at sort of what we've laid out as the scope of practice, it's very, 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 very similar. But there's a few things that in the context of MIMS and pre-hospital care doesn't really make sense, or doesn't really have the same logistical things as we do here in the hospital. So the big example of that is pressure management. So in scope of practice for MIMS, you can give paramedics can start epinephrine drips and dopamine drips, obviously. So you can manage those, you can care for those, right? But in the hospital, that's typically that's not our first line pressor, right? So it doesn't really work quite the same way. It doesn't make sense as much because we're not using those two pressors as our first line. We're using Levophed. So why should we allow somebody to give epinephrine but not allow them to give Levophed? Doesn't really make sense in our context. So we wanted to expand it out to allow you to have that scope as well. So it's not really a totally new scope. It's just expanding out to make it make sense in our context. So with that, though, we got to make sure that everybody is on board and everybody sort of has the understanding and the tools to do that appropriately and to manage those safely and effectively. So this is the first step in that, is really to sort of give you the education to make sure everybody's sort of on the same playing field from an educational standpoint and has the knowledge necessary to manage these pressors. So down the road, you might be actually managing these patients on a transport by yourself. We're going to go into a little bit of sort of the caveats to that, but you might be. So you might take a patient that's on Levophed by yourself, and you're going to need to know how to titrate those things and manage those things. It's also in your scope to initiate these things. So if you're on a level 3 transport and the patient starts to deteriorate, you should be able to initiate the first line pressors and things like that under order. So that's kind of the reason why. Step number 1. Bridget, yes. Hold on, you're muted still.
Sorry, Phil is going to be jumping on in just a second. He is my orientee. He's a paramedic orientee. So he's going to be jumping on real quick. I was going to send him a link.
Yeah, do you have the link, Bridget?
Yeah, I have it in my email, so I was going to send it to him.
Okay, and I'm sending, Andrea is trying to get on too, so I'm sending her the link as well. All right, so I'm going to keep going, Bridget. This is just introduction. I'll make sure he's on before we get into the meat and potatoes and stuff. Oh, there's Andrea. Beautiful. So that's why we're doing this class. There's going to be more to it. This is the first step. We're going to do some simulation. We're going to make sure everybody's comfortable with the pumps, hands-on training and things like that as well. Just to make sure you guys have been doing this. A lot of you guys have been doing this for quite some time, but you haven't been doing it necessarily in the role where you're responsible for these things. So we want to make sure that everybody's comfortable with that and has that education. So the next steps will be hands-on training, some simulation based stuff, and then also eventually there will be a pharmacology exam that everybody will take too, to sort of just make sure everybody's got the baseline there. And it's nothing to be really worried about, you know. So it's the information that we've covered. It's either information we've covered here or information that you know from your previous pharmacology studies and your paramedic scope of practice. If somebody were to fail one of those tests, you know, it's not like you're kicked out the door, booted out. You know, we'll just work with you to make sure that you understand the concepts and get you through the test. And then this is the beginning really of a paradigm shift. So this is the most exciting thing for me because, you know, I would say I'm adopted into the MS world, right? I'm a nurse. I didn't come in with a paramedic background, but I really feel a part of that team, and I really feel invested in your group and in paramedic, and wanting to see really you be recognized and recognized for what you can do, and really allowed to do what you can do inside the hospital. So that's been something that I've just really kind of had a heart for the last couple of years, and we're getting there. And we always talk about in our group that we're a team, we work as a team, you know, and I think that's true, but sometimes a little bit aspirational, right? In that because of some of these structural things, it's difficult to really fulfill that to its fullest extent. So this allows us, I think, to move forward, remove some of the structural problems that causes some division between paramedics and nurses, and allows us to be much more united, I think, in our care for the patients. So why I say this is a paradigm shift is because this scope of practice isn't primarily, the reason we're making this change in scope of practice is not primarily so that we can send more patients as a level 3 team, right? So we don't need nurses as much or anything like that. That's not, that there will be some changes in how we dispatch, but that is not really the primary reason. The primary reason made this change is because you have the scope of practice, and we want to recognize that. And where we see this, I think now, is sort of on these calls where we're going on a call. Bridget and I'm gonna pick on Bridget because I can see her face. Bridget and I are going on a call, right? And patient needs some fentanyl or, you know, some other drug, and I gave the fentanyl, right? Like we've all done that. It's like, you know, we know that Bridget actually gave the fentanyl, but I've got to document it. I've got to say that it was given by me. Well, that will no longer be the case, right? That's now not at all sort of where we're going to do. You may be with a nurse, but you can still give the fentanyl, right? Or you can titrate the pressor. So so it really is truly going to be a team approach. Just like if 2 nurses went on the call, it doesn't really matter who with the primary nurse. Either nurse could document the drugs they give. It'd be a collaborative approach. You know, nobody's doing things outside of, you know, communicating it. Nobody's just like going rogue and doing stuff without telling the other person. It's still communication. It's still sort of a collaborative team approach, but now you really can take credit for what you do. So all that stuff that's in your scope of practice now, bam, you can chart it, you can document it. There should already be changes in your profiles if you've done the My Learnings. that you've got access to the EMR now, you've got access, you can chart your assessments, like anything that you can do in your scope of practice, you can chart, right? And that's the beauty of this whole thing too. Hey, Phil, how's it going, man?
Hey, I thought my my computer somehow died, so I'm on my phone over here.
No worries, no worries. If we'd known that there's going to be so many people in one group, we could have just put it up in the conference room or something, but no worries. So that's the paradigm shift. We are truly taking a collaborative approach to caring for our patients at this time. There's going to be a difference between what you can do in your scope of practice and what you're dispatched as. So again, with the pressors, this is a good example. There are patients, pressors are now going to be in your scope of practice, right? All pressors. You're going to be able to titrate, you're going to be able to manage them, right? But if you have a patient that's, really sick on multiple pressors and pretty hemodynamically unstable, you want the resources, you want to have the right resources. So that patient that's on multiple pressors requiring lots of titrations, we're not going to dispatch that as a level 3. We're still going to dispatch it as a level 4 because you don't want to take that patient by yourself. So we want to make sure we have the right resources. So basically, sort of what we kind of landed on is coming up with some dispatch criteria where we could send the right resources. So when it comes to our pressors, it'll be, if they are on a if they're on a stable dose of pressor, one pressor, and they haven't had like increasing titrations in the last hour or two, we'll consider that sort of a stable dose and potentially send that as a level 3 team. So it could just be a paramedic and the EMT on that call. That's the dispatch criteria, right? But if it's more than that, we'll send a level 4 team so you have the right resources. And then of course, like if you get to the bedside and you're like, this patient is a lot sicker, I need additional resources, you can call and ask for a nurse to come up, or say we're going to need to wait for a nurse or anything like that. Just like always in our operations, when you need additional resources, you get additional resources, right? You're not gonna be denied things if you ask for them. So does that make sense? There's a little bit of a difference between your scope of practice and the dispatch criteria, and how that's sort of written in there. So if you do get dispatched on the one that's multiple pressors, right? That's not really, I wouldn't say it's outside of your scope. We're just not going to dispatch it as a level 3. So you would still be able to manage those pressors along with the nurse, but you're not going to be doing it by yourself.
It makes sense to have additional resources. I like it.
Yeah, I mean, does that feel comfortable for people too, like that approach?
Yes, absolutely.
All right, awesome. And then I said it already, but just want to emphasize, if you feel like you need resources, you can always ask, right? There's probably going to be the challenge with doing it this way is it may be a little bit difficult to dispatch. It's might require a little more digging. So there may be some errors where you might get sent up as a level 3 and you get there and you're like, oh, nope, this is a level 4. So if that happens, just call and ask for the resources. Right? All right. So this is exciting for me. I hope this is exciting for everybody else, but really, I think this is the beginning of sort of a really new paradigm shift, and really just a better fulfillment of what our goals and our aspirations are as a team. All right, so objectives for this class. Basically, we're gonna high level description of hemodynamic monitoring systems, kind of give you awareness level of some of the different advanced hemodynamic systems that you might come across. We're going to discuss the patient conditions, who and how we monitor patients. We're going to talk about normal values for some of the hemodynamic pressures and what those indicate and how to manage them. We're going to talk a little bit about the physiology of hemodynamics. We're talk about preload, afterload, contractility, cardiac output, etc. And then we're going to talk about the pharmacology agents that goes along with them. So what kind of drugs we're going to use to manipulate these things and how to treat these patients, right? So that's basically the overview. Some of this, like I said, I want this to be interactive and sort be the right information for you. So please, ask questions or tell me, Sean, we know all that stuff. We can go a little faster. So here we go. So we'll start off with pop quiz. Abnormal findings that cause a low CVP or central venous pressure are 1, hypovolemia, 2, tachycardia, 3, cardiac tamponade, or 4, hypovolemia. Which of those options causes a low CVP?
What was A?
Oh, hypervolemia, tachycardia,
Okay.
cardiac tamponade, or hypovolemia.
I'm going to go with D, hypovolemia, but that's just a guess.
Who agrees with Andrea? Anybody agree? You can use the chat too if it's easier to use the chat than coming off. There we go. Oh,
Yes.
you were using the chat. Sorry, Phil. I just saw it. 4. Yep. So hypovolemia. Exactly. That is correct. Nice job, Andrea, and everyone else. So hypervolemia. You would typically expect to see a high CVP with hypervolemia. Tachycardia. What might you see with tachycardia?
An increased CVP?
You could, right? It kind of depends. You could actually go either way. So it's not going to be definitive either way. So you could have tachycardia, if it's so tachycardic that you're not really getting good cardiac output, then you would see a backup of your fluid and increasing CVP, right? Or if you're tachycardic because you're hypovolemic, then you're going to see, the low CVP. So it doesn't necessarily tell you, it could go either way. And then cardiac tamponade, you would expect to see an increased CVP with cardiac tamponade for sure. All right, you passed the first test. All right, so basically, when we're talking about this is advanced hemodynamics, this slide, we're talking about principles for advanced hemodynamic monitoring. And basically what we're doing is we're using pressure gradients. We're measuring pressure gradients that are occurring in the body. We're translating those pressure gradients, through pressure tubing, through a static column of water to transmit that pressure up to a transducer, which translates the pressure signals into an electrical signal and draws out a waveform on the monitor, right? And then we can look at that waveform, we can interpret the waveform itself, and we can look at the numbers that correlate with it and really kind of develop a standard set of normal values for various parameters, and then use that to treat our patient accordingly. Ultimately, right, why do we monitor hemodynamics? Ultimately, there's kind of lots of things. We use it to give fluids. We use it to figure out, do we need to give pharmacology support, etc. But ultimately, the main reason is we're trying to assess end organ perfusion, right? So keep that in mind. Perfusion is always the key here. It's not just to get normal numbers, right? It's really to make sure that we're perfusing the patient's organs. So, we can actually, we'll talk about some of these pressors and things, and you guys probably all transported patients that are on high dose pressors, and they might have pretty numbers, but what's happened to their fingers and toes?
They get the levotose.
Right, they turn black, they get necrotic, right? So obviously, even though we have pretty numbers, we're not actually doing great with perfusion, at least not peripherally. And usually in that case, it's, you're kind of sacrificing peripheral circulation for core organ circulation, but it's just kind of to illustrate the point that pretty numbers does not always equal perfusion. We need to assess the whole patient, and that's the goal, is perfusion. All right, so think about common hemodynamic monitoring methods. This is not just advanced, so think about from basic all the way to advanced. What are some common ways that we can monitor and assess a patient's hemodynamics?
I mean, you can look at their neurostatus, you can look at, pulses, you can look at their numbers, their labs, If they have invasive lines, you can, use certain readings
Man, you
from like
nailed
their
it.
PA catheter or CVP, EKG.
I think you hit them all. Nice. So, Bridget, thank you for saying the assessment and the neurological part of it. Don't ever forget the basics, right? It's just like with always start with BLS and a cardiac arrest, right? Always start with your basics with anything. Start with your assessment. Start with those things. The neurologic assessment is so valuable. What do we know about the patient's brain as far as when it comes to perfusion and oxygenation? How sensitive is the brain to oxygenation changes?
Extremely sensitive.
Yeah, extremely
So
sensitive.
mental status is one of the first things that changes.
Exactly. You don't have any reserve in your brain, right? Your brain tissue cannot switch into anaerobic respiration, which other parts of your body can. So if the brain is not being supplied with oxygenated blood, you will see a change immediately. So exactly right, Bridget. This is going to be one of your first changes. So make sure you're assessing that. Now, some of our patients, the neuro assessment might be obscured for multiple reasons, right? They're intubated and on sedation, and we don't really have that to go by. So sometimes we forget about the basics because we don't have that available. But certainly use that. Use your basic assessment skills, neurologic exam, the pulses, like Bridget said, presence and quality of the pulses, the skin, right? Doing your skin assessment is extremely important. Is the patient cold and clammy, or or do they seem to be perfusing well their skin? Your EKG just kind of gives you a little bit about what their heart is doing and whether it's in a perfusing rhythm or things like that. Non-invasive blood pressure, of course, is a go-to for us, and then A-line. Labs. Bridget, you mentioned labs. So what are some labs that might tell us about the perfusion status of our patient?
I would say lactate would be a possible one.
Nailed it. Yeah, lactate. So that's going to be the big one. I mean, there's multiple. We would look at multiple things: hemoglobin, seeing whether the labs are concentrated and they look dry and things like that. But lactate really kind of is a measure of perfusion directly, because why would the body, or I guess first of all, if you have a patient that's not perfusing, are they going to have a low or a high lactate? High, right? And why is that?
Anaerobic metabolism.
Anaerobic metabolism.
Yeah, man, you guys, it's early in the morning, but you guys all had your coffee, I think, this morning. You're nailing it. Exactly. So when the tissues are starved of oxygen, they switch over to anaerobic respiration, which produces some energy, but also produces the byproduct of lactic acid, right? So as we build that up, we can measure that, and we can see that there's high lactate means somewhere in the body. It's not specific, right? It doesn't tell us exactly where the problem is, but it tells us that there's a problem with perfusion, right? So that's a great lab. That's one of the reasons why I'm excited about the EPOC devices. Is another tool that we have that we can measure perfusion, but we can also sort of remeasure and reassess and see once we have sort of done some fluid resuscitation or done some blood, we can see whether we're making a difference. And then cardiac output, measuring cardiac output. We can do that through a PA catheter. We can do that through the Pico device, which we'll talk a little bit about, and the Edwards flow track. Those are just some examples. There's other ways, but those are the most common things we're going to see.
I don't think I know what the Edwards flow track is.
I was about to say that too, Bridge.
We're starting to see it a little bit. You might have seen it. I'll show you. I got some pictures in here, but we'll talk more about it. And you might see it. The WICU is starting to use it a little bit more, and some other places will probably start to switch over. In fact, I think down the road, actually, we're probably going to, like, I know the NCCU uses the Pico. They're probably going to be switching to the Edwards. So we'll see it more. All right. So when we talk about hemodynamics, you guys know me, I'm a simple guy. I try to keep things, I try to understand things at the most simple level, and that's the way I sort of try to teach things. So when you think about hemodynamics, it actually is simple, right? You have a pump and you have the pipes. You have the pump and the pipes, right? So we think about the pump being our heart, we think about cardiac output, right? And then we think about the pipes. How much vascular resistance, are the pipes of the vasculature going to provide? And through this lecture, we're going to go through both of these things and talk about them. The way this lecture is structured is we're going to go through the physiology, talking about cardiac output and all the components of it. And as we go along, we're going to sprinkle in some of the pharmacology, I can't say the word, pharmacology methods that we would use to treat those things. So that way we're connecting the pharmacology to the physiology as we go through it. I think it's a nice way, kind of keeps things fresh and immediate application. The only downside is that sometimes drugs have multiple effects on multiple things. And so, where exactly you place it may be a little bit of a judgment call. So we'll talk about some drugs that kind of cross categories and things like that. So starting off with the pump. So hemodynamics, we'll start off with the pump, and we're going to talk about cardiac output. Cardiac output, I think you all pretty familiar with cardiac output, liters per minute. It's how much blood is being pumped out of the heart every single minute, right? And so there are two main factors that determine your cardiac output, and that would be your stroke volume, which is how much blood is pumped out on each beat, and multiply your stroke volume times your heart rate, how many times that heart beats a minute, and there you have your cardiac output, right? So those are the two factors. And then the things that make up your stroke volume would be preload, contractility, and afterload. And we're gonna go through each of those things. So this slide here kind of gives the structure of how this lecture is going to be. We're going to go through each of these elements and talk about them. So first being cardiac output. So normal cardiac output is 4 to 8 liters per minute. So try to keep some of these numbers a little bit in your mind. We'll have some scenarios at the end, and you might need to know some of these things to help assess the patients that we go through. But cardiac output, normal 4 to 8 liters per minute. And then we have cardiac output, and then we have cardiac index. Does anybody know what cardiac index is, and sort of what's helpful about cardiac index?
Cardiac index is it puts it in perspective. So what is normal? Meaning, like, you could have a football player who could have, a 2.5 or whatever, and you could have a little old lady that has a 2.5. And it really is, figuring out the difference between them.
Yeah, absolutely right. So if you just look in the calculation here, you can kind of see that, right? So in order to get your cardiac index, you take your cardiac output and you divide the cardiac output by the patient's body surface area, and that equals your cardiac index. So you can see that the normal cardiac output, 4 to 8 liters, that's a broad range, right? So as Bridget was describing, you might have a little lady who weighs 70 pounds. She probably doesn't need a cardiac output of 8 liters, right? She's probably on the lower end of the 4 liter size. But you have a 350 pound, 6'5" football player. If that 6'5", 350 pound football player had a cardiac output of 4, would that be sufficient for that patient? No, even though he's in the normal range, wouldn't be sufficient for that particular patient, right? So there's a little bit of variability there. Whereas with the cardiac index, because it's taking into account the size of the patient, every patient needs to fall within that range, right? So you might have a patient who's got a normal cardiac output, but a low cardiac index, in which case you would still treat that patient as a low cardiac output patient. The other caveat to this is normal. These are normal ranges under normal circumstances, under normal metabolic conditions, right? So as your metabolic need changes, your cardiac output needs are going to change, right? So what are some things that might cause you to require a higher cardiac output than normal?
Sorry, can you say that again?
Mm-hmm. Yep. So these normal ranges are the normal ranges under normal conditions, right? So there are scenarios where you're going to require a higher cardiac output, than what the normal situation is. So what are some examples of times where you would be in a state where you would require a higher cardiac output?
Exercise.
Ah, there you go, exercise. See, I knew you would say that one, Andrea. See, that never registers in my mind, exercise. But yeah, exactly. So you're using your muscles. So we call that you're increasing your metabolic state, right? You're increasing your basal metabolic, or you're not increasing your basal metabolic rate. You're increasing your metabolic rate. You're in a state where your metabolic rate is higher than normal, and therefore you need more perfusion, right? So when you're exercising, your cardiac output is going to increase, right? And that's going to be then appropriate for you. So that's a great example. What any other
medical wise, what about like sepsis or shock, any kind of, cardiogenic shock, any kind of shock, really, you're going to have to increase your cardiac output. So
yeah, specifically, so sepsis would be a great example because your tissues are working harder, right? There's an infection going on that's placing a greater demand on your tissues to require more oxygenation and more perfusion. So you're going to require a higher cardiac output than normal, 100%. Some of the other states of shock are actually maybe on the other side of things. They're on the demand. So you think about supply and demand, right? So the metabolic state is the demand side. This is how much oxygen we require. And then you have the supply side. This is how much perfusion the heart is delivering, right? So sepsis is going to be a combination of a high demand and a low supply, right? So it's really kind of, the seesaw is really tilted. Something like cardiogenic shock doesn't necessarily change, in and of itself, I should say, it doesn't necessarily change the demand, but it lowers the supply. You're not able to supply the normal amount. But sepsis is the big one that I was thinking of. There's definitely other times. If you have a fever, even without sepsis, could be like neurogenic fever or something like that. That's going to increase your metabolic rate and all those kinds of things. So that's just to say that just because the patient might be in the normal range, there might be other things going on that require still more cardiac output. So just keep that in mind, and especially think about sepsis in that. All right, so here are some of the devices that I was talking about. So up here, this is the Pico device. This is what you'll currently see in the NCCU. I think PEDS uses it as well. All these monitors here, we're not usually transporting on these. You'll see these on the room. We usually have to disconnect if we're going to go on a transport with these. So this is the Pico. This is the Edwards Vigileo, or I forget the name of the actual monitor, but this is the Edwards version. So this again is a separate monitor, just like the Pico is, that would plug in, and you would get all these different numbers. These are just two different screens on the same monitor. So you can go through different screens and get all your cardiac output numbers, stroke volume, all those kinds of things, right? So you'll see both of those. Like I said, the WICU is starting to use the Edwards a little bit more. Anesthesia, I think, uses this. So you might see that there too. And then this one down here is our regular GE monitor. So this can actually give us some cardiac output information as well. Our swans, the ones we use, will hook up to the GE monitor, and we'll get our cardiac output monitoring through the GE monitor. So you'll see that kind of down on this pane here. You see the cardiac output monitoring. So those are the monitoring devices, but then there's tools to get the information, right? So this is these things here. These are the flow tracks, the Edwards flow tracks. So this all the things on this page here are Edwards devices, and they all plug into that this Edwards device here, right? So they actually have non-invasive measures of cardiac output. So this here is like sort of like a pulse ox. It's called the ClearSight cuff or something like that. So this goes on your finger, and it sort of measures the pulsation in your extremity, and makes calculation to calculate your cardiac output, your stroke volume, all those things. So pretty wild. Gives you an awful lot of information without having to do anything invasive at all. So this is a fairly new technology, or at least fairly new to really be widespread and go under wide use. This is being trialed in the NCCU and things like that. So we'll probably see this non-invasive mode you know, as we start to see more people adopt this. It seems to be pretty accurate from everything I've read. Obviously, it's not as accurate as sort of a direct measurement, but it definitely gives you a place to start and sort of a baseline as you're treating your patients. So going from the non-invasive to the minimally invasive, this is the FlowTrack device. This is a really cool, I think this is really cool. It provides you with really good information. And basically, the only thing you need for this is an A-line. That's it. So what you do is you take the this piece here, or these are kind of the same thing. You take the regular transducer off and you replace it with this device. And this actually has two of the little connector pieces. One goes to the monitor to give you your blood pressure, and the other goes to this device to give you all your cardiac output monitoring. So this does a similar thing where it measures it measures basically the waveform itself and uses the waveform of the A-line to calculate out cardiac output, index, stroke volume, all those kinds of things. So this is you know, a little bit more invasive. You need an A-line, but that's not that big a deal. Most patients that, you know, you're doing this stuff are going to have an A-line. So this sort of exponentially increases the usefulness of an A-line is kind of the way I look at it. So this is a wonderful thing. And this also, you know, going along with this non-invasive, this is also coming and being seen in some of the ICUs. And then you basically have your catheter versions, right? So the kind of the gold standard is the Swan Gans catheter. So that's going to go, you know, into your pulmonary artery, and you're going to use it to measure cardiac output and all those things, as well as pulmonary artery pressures and things like that. There are there's a couple different ways that you can measure cardiac output with the Swan. You can actually hook the Swan up to the Edwards device as well, and actually has a fiber optic sensor and actually directly measures the flow across the catheter and gives you a continuous cardiac output. So that's pretty cool. Or what we typically do here at Hopkins is we use what's called the thermistor technique, which I'll tell you a little bit about in a minute. So you have the continuous cardiac output from the Swan. There's also catheters that are regular central catheters that also can give you continuous cardiac output with that fiber optic sensor as well. So that's pretty neat as well. So the thermodilution technique, basically what that does is you can see the picture here of the heart, and you've got the pulmonary artery catheter coming down through the atrium into the ventricle and then up into the pulmonary artery. And we have different ports along the way. So we have the distal port here that's right at the tip of the catheter. And then we have the proximal port here. And then we can take measurements. We can take the temperature measurements at the tip. And basically what we do is we inject a known amount of cold saline. So we're going to know the amount of saline we're going to inject, and we're going to know the temperature of the saline we're going to inject. We're going to inject that through the proximal port here, and then the patient's cardiac output is going to carry that fluid up through the pulmonary artery and across the thermistor, right? So as that cold fluid passes the thermistor, it changes the temperature of the fluid around it. So you're going to see a temperature change, right? And then you're eventually going to see all that temperature change be dissipated and go back to normal, right? As that sort of bolus of cold fluid sort of gets dispelled to the body, you go back to normal. So the higher the cardiac output, the faster that whole process is going to happen, right? Because your blood is just pushing that fluid through. So it's going to be a quick decrease in temperature and then a quick return to normal. If your cardiac output is slow, or as low as sluggish, then it's going to be a much more prolonged process, right? So the device measures the temperature change, and it makes calculations based on how fast that temperature change occurs, what the cardiac output is. And that's called the thermodilution technique. And basically, the downfall of this is that you sort of have, it's a manual process, and it's a little bit up to technique. So if you inject sort of unevenly or inject too slowly, you might have some inaccurate results. So typically when you do this, you do it a couple times and you average the results together and use the average of those. So does that make sense, that technique? The Pico device, it uses actually the same principle. It uses a thermodilution technique. So the Pico device is a little bit less invasive than a Swan, but it's more invasive than the Edwards flow track. So for a Pico to work, you need a central line, subclavian or IJ central line, and then you need a femoral A line. And basically, it's doing the same thing. You're injecting a known amount of saline, cold saline into the system, and it's going to measure the temperature at the femoral site. So it's going to do the same thing. It's just using two different sites than you did with your PA catheter. So the advantages of this is you don't need a PA catheter, but the disadvantage is that you still need a central line and you need a femoral A line. You can't use it for a radial A line. You got to have a femoral A line. So that's the downside of that. All right, so those are just a broad overview of the different devices that you'll come across. We don't really use those in transport, any of them. They don't really sort of work well in the transport environment. So that's not something we're going to be monitoring necessarily in the transport, but it's good to know the information and what you'll see when you get to the patient's bedside. And it's also good to know the values, because that'll help determine your care along the way. So the next component of cardiac output that we're going to talk about is heart rate. And obviously we think about our central nervous system controlling our heart rate, and we have our sympathetic nervous system and our parasympathetic nervous system. So our sympathetic nervous system, let's get into a little bit of the neuro portion of this and review about our neuroanatomy and how our nervous system works. So the sympathetic nervous system, first of all, what is it going to do to our heart rate? Increase it. Yep, exactly. So it's going to increase our heart rate. And how does it do that? What are the pathways it uses to increase the heart rate? It's going to go through the sympathetic nervous system runs through our spinal column, right? So the nerves run through our spinal column. They exit, I forget what level, but basically go to the adrenal glands, right? Stimulate the adrenal glands to release what?
Adrenaline.
Epinephrine.
Yep, exactly. Release catecholamines, including epinephrine, norepinephrine, dopamine. Right? It releases all those catecholamines, which bind to what receptors? I'm getting deep on you, right?
Neuroreceptors.
Yep, the neuroreceptors. So they're going to be the big ones we talk about are that are relevant to this context are alpha receptors and beta receptors, right? So the beta receptors are located where? Anybody remember?
Heart and lungs.
Heart and lungs, perfect. So in the heart, those are beta 1 receptors. In the lungs are beta 2. And how do you remember the difference?
B is 2 lungs and A is 1 heart.
Exactly. You have one heart, so that's beta 1. You have 2 lungs, that's beta 2, right? So on the heart, it's going to increase cardiac output, or it's going to increase contractility. It's going to increase the heart rate, right? And in the lungs, it's going to bronchodilate. So all this stuff is basically preparing your body for action. And then on the blood vessels, it binds to alpha receptors, right? So the alpha receptors cause your blood vessels, when they're activated, cause your blood vessels to vasoconstrict, right? So it increases your blood pressure. So that's what your sympathetic nervous system does. How does your parasympathetic nervous system work? Or what pathways does it use?
I think it uses peripheral pathways at the top and the bottom of the spinal column. I could be wrong though.
So so at the top of the spinal column, what's the big nerve that controls sort of the parasympathetic response?
Let's say the vagus nerve.
Vagus nerve, right? Exactly, and that's actually coming from the top of the spinal column and actually the brainstem, right? So that's directly coming to the brainstem. It goes innervates to the heart, and it releases acetylcholine, right, which causes the heart rate to lower. Right. Now, the important thing to recognize, we think of parasympathetic and sympathetic as sort of being two different pathways that sort of switch on and off, but that's not exactly true. They're actually both they're both working all the time. So your heart's always getting signals from your sympathetic nervous system as well as your parasympathetic nervous system, right? And then in certain states, you might get more of an overwhelming sympathetic response, like you get scared or something like that, and it causes an increase in how much sympathetic response you get, and you start to have the effects of the sympathetic override the effects of the parasympathetic. And then the reverse can happen as well. Like when you suction a patient and you overstimulate the vagus nerve, you're not taking away the sympathetic side of it, but you're overwhelming the sympathetic side, right? You're giving so much stimulation to the vagus nerve that it overwhelms the sympathetic side of the nervous system. And the reason why that's important to realize is that there is one specific drug. What's the one drug we give? What's the first drug that we give if we have a patient that's bradycardic? What's the main drug we're giving for that?
Atropine.
Atropine, right? And does atropine stimulate the heart directly?
No.
No, it does
No,
not.
it's vagus nerve.
Yeah, it's blocking the vagus nerve, right? So it's not actually stimulating the heart. It's just taking away some of that vagus stimulation, and it's allowing your body to naturally increase the heart rate by the mechanism it's already using. So that's why that's sort of important to understand, because we're not whenever we're affecting some of these things, we can do it by two mechanisms. We can stimulate the thing we want to increase, or we can block the thing we don't want to have. So we have drugs that stimulate and we have drugs that block. All right, so our therapeutic interventions. We have a low heart rate. We talked about atropine, right? We can also pace and directly increase the heart rate of that patient. And then we can use different vasoactive agents as well. If we have a high heart rate, we all know that high heart rates can also cause a low cardiac output, right? Because if the heart rate's too fast, then you're not increasing filling time, right? Or you're not allowing for adequate filling time. So you're basically just pumping a dry pump, right? So if it's too fast, we can actually get a decreased cardiac output. So we have several agents that we would give for that. We have amiodarone, beta blockers, and calcium channel blockers being the main categories. So atropine, we started to talk about this already. It's an anticholinergic medication. It inhibits that response. So some side effects are going to be inhibiting salivation, secretions, and inhibiting bradycardia, right? We give it for symptomatic bradycardia. Remember, we're not just treating a number, we're treating the patient and the symptoms. So we're giving it for symptomatic. And then dosing, so it traditionally always been 0.5 milligrams Q5. I've recently learned that ACLS guidelines are now 1 milligram. Is that right, Bridget and Eric? So that's, when did that change? And then
It's always been 0.5 to 1.
it's always been 0.5 to 1.
Mhm.
So I guess we're just going with the higher end now. So you can give that either dose and max of 3 milligrams. It's very rapid onset. It lasts for a decent amount of time, 2-3 hours, right? There's no absolute contraindications for atropine, but there's times when it's ineffective. Hypothermia, a lot of meds are ineffective in severe hypothermia. If the patient's already tachycardic, I'm not sure why you would give it. It can cause some tachycardia, I guess. It can cause pupil dilation. So remember that for your neuro assessment. After you've given somebody a slug of atropine, cause some pupil dilation, right? So I think you guys are all pretty familiar with atropine. I don't think we need to stay on that too long. Dopamine, this is another drug that would be in your wheelhouse already. So what can you tell me about dopamine?
That is a vasoactive drug that also increases the cardiac output, but it also will constrict the blood vessels.
Right. So this is one of the drugs I was talking about has many mechanisms, right? So it causes stimulates beta 1 and beta 2 receptors, which as you said, Phil, will increase the heart rate. Also increases the contractility of the heart. So we what do we call that when a drug that increases contractility? Remember the name for that?
Is that an inotrope?
Yep, exactly. So this is a chronotrope, meaning it increases the heart rate. It's also an inotrope, meaning it increases the contractility, right, of the heart. It's also a adrenergic, which is adrenergic means the alpha receptors. So it stimulates your alpha receptors, which, like you said, Phil, causes vasoconstriction. So it's going to cause an increase in blood pressure. It also stimulates beta 2, which are going to do what?
Dilate the airway, the
Yep.
alveoli.
Yep, bronchodilate. Yep.
Bronchioles.
Yep. Yep. So we would give this in symptomatic hypotension and bradycardia. Now this drug is can be challenging. It's not usually our first line pressor in the hospital. And the big reason for that is some of this stuff is dose dependent. So we just went through all the things that it affects. It affects like everything in the sympathetic nervous system, right? It bronchodilates, it increases the heart rate, it increases the contractility, it increases the vasoconstriction, right? So it's not a very selective drug. It's kind of like hitting on everything. And one of the main problems you have with dopamine is it really has a strong beta 1 effect. So it really increases the heart rate pretty significantly. Oftentimes it's sort of it stimulates that more than it does the vasoconstriction. So it has a stronger beta 1 effect than it does alpha receptor effect. So if you're giving it for somebody who is already hypotensive, they're probably already tachycardic as well, right? Because they're trying to compensate. So now you're giving them a drug that's really going to increase their tachycardia further and not cause, cause vasoconstriction, but really kind of overdoes the heart rate. So that's the biggest challenge, is that you kind of give this and you just get so much tachycardia that it's kind of hard to deal with the rest of it. It does change depending on the dose. You get sort of more or less effects on certain receptors. The dopaminergic sort of renal dosing is sort of an old school thing. They used to give like low dose dopamine to kind of provide like what they call a renal push, which would theoretically provide more perfusion to the kidneys, and cause some better urine output, things like that. That's sort of, there's not a ton of evidence to really show that's helpful. So that's kind of an old practice. And then at the 2 to 10 mics per kilo range, you get a lot of beta effects, right? So you get the increased contractility and increased heart rate. And then as you get above 10, you start to get adrenergic effects in addition. So these things, the adrenergic effect doesn't replace the beta effect. You get both effects now. You're getting that heart rate effects and the adrenergic effects. Some things to be worried about, of course, tachycardia, and you can have other tachyarrhythmias. I've definitely put people into, all kinds of, I put them into VTach, I put them into all these like multifocal PVCs and stuff like that with dopamine. It could cause a ton of those things. Any kind of extravasation into the tissue is going to cause a lot of tissue necrosis. So you got to be really careful of that. So anytime you're using dopamine, we can use dopamine through a peripheral line, but definitely want to use it through a central line if possible, or an IO if possible. The other thing about dopamine is, especially, we always want to think about perfusion, right, and demand. So if you have a patient that sort of has a weak heart, this really puts a lot of demand on the workload of the heart, because it's causing an increased demand to the cardiac tissues, right? So because it's working harder, it's making the heart work a lot harder. So you got to be careful in your cardiac patients. This actually is used in a fair amount of cardiac patients because it has the inotropic effect, but you do have to be careful if you've got a patient that's already has an ischemic heart or something like that. It's going to potentially make that worse because it's increasing the workload of the heart. All right, so so dopamine would be a good drug to use for a heart rate issue, and it is actually used. If you go down the pathway, you give atropine first. If atropine doesn't work, you can either pace the patient or you could put them on a dopamine drip, and it actually will work pretty well for the heart rate side of things. It just doesn't work, as well as a pressor. So going the other way, if we want to slow a patient's heart rate down, we have a couple options. One is metoprolol. So this would be in our beta blocker category, right? So now we're blocking beta 1 receptors. Metoprolol is nice because it has mostly beta 1 effects. It doesn't have as much effect on beta 2 receptors. So that means that you're not going to get as much blocking of the bronchial passages. It's used basically for narrow complex tachycardias to bring the rate control down, and for atrial dysrhythmia. So if you have AFib with RVR, you might give metoprolol to rate control the patient. The dosing of it is 5 milligrams IV push. Give it slow. You repeat it 2 times. It's a very, very effective drug in bringing down somebody's heart rate. The downside to it is it's pretty long lasting. So oftentimes, if you've got a patient that's hemodynamically a little bit tenuous, you may not start with metoprolol, only because if you give metoprolol, you're basically committed to that. You can't just wait it out. You've got 5-6 hours before that wears off. So you don't want to overshoot and cause your patient to be more hypotensive or anything like that by giving metoprolol. So that's the downside, but it's very, very effective in heart rate control. You do want to be careful if a patient's got a history of bronchospasm because of that potential beta 2 effect, but probably metoprolol is going to be one of the better agents for that, because it really does have limited effect on beta 2. Labetalol is another beta blocker. This is non-selective, so this is going to cause beta 1 and beta 2 blockade. So we have to be very, very cautious in our patients with reactive airway disease, asthma, etc., because this could actually trigger sort of an asthma attack, because it's going to trigger some bronchial constriction, which we don't really want. We want to use it more for the beta effect, but it has both. The other nice thing about labetalol is it actually has alpha effect, so it causes alpha blockade as well, which causes a decrease in blood pressure, causes vasodilation and a decrease in blood pressure. So this is a good drug to use in a sort of a hypertensive emergency, and a good drug to use with like a aortic dissection patient where you want to cause decreased heart rate and decreased blood pressure. Really nice drug for that. Again, the downside is it's pretty long lasting, so you've got to be careful not to overshoot your blood pressure control, and really to keep a real close eye on the hemodynamic effects. The dosing for it, initial dosing is really 10 to 20, really kind of more on the 20 side, IV push initially. And then if you don't get a response or adequate response, you actually double the dose and you give it again. And then you double the dose again and you give it. So basically start out with 20 milligrams, wait 10 minutes, then give 40 milligrams, then give 80 milligrams. So pretty high dosing. You can give it as a drip as well. And sometimes you'll see this for like aortic dissections, patient on a drip. And then there's Esmelon. So another, continuing our beta blockers, Esmelon is a selective beta 1 blocker, similar to metoprolol. It has much less effects on beta 2. We're going to use this for narrow complex tachycardia and for rate control for dysrhythmias. And this is also really our go-to for aortic dissections as well. The advantage and disadvantage of Esmelon is its duration is extremely short, 15 minutes, right? So you're almost always going to be given this as a drip. You'll give a loading dose here first, or you give 500 mics per kilo loading dose, and then start an infusion of 50 mics per kg, and then continue to repeat the bolus dose and titrate the rate until you get blood pressure and heart rate control. So it really does require some pretty aggressive titrations and bolusing to get the initial control. And then and then you have to leave it as a drip because it's not going to last. The reason that's an advantage is if you overshoot with Esmelon, you could turn it off and it wears off pretty quickly. So pretty forgiving in that sense. You want to, again, with everything else, you want to be careful with patients who have asthma or reactive airway disease.
I have a question. Is Esmelon the one in aortic dissections that we preferred it as a first line? Okay, because of the fact that it's short acting and you can turn it off and kind of, okay.
Yeah, so there's two reasons why Esmelon is sort of the first line. The one is in these patients, we want to cause, there's two forces that we want to decrease. We obviously what we're trying to do is prevent an extension of that dissection, right? So we've got basically the walls of the vessel ripping apart. So we want to prevent that to spread any further. So we do that by two ways. We want to decrease the pressure, the overall pressure. So we're not, if we have really high blood pressure, that's going to cause the tear to go further. That's one. So we want to decrease the blood pressure, but we also want to decrease the heart rate itself. And that's actually shown to be more important than the overall blood pressure. So that's really what it's that bolus force that keeps hitting it that's going to cause that thing to tear further. So we want to actually get the heart rate low, even into the 50s, to decrease the amount of time that sort of bolus of pressure hits that tear and extends it further, right? You think of like if you're trying to tear something, a piece of paper or something, like you kind of do like these yanks to make it tear further. That's basically what you're doing with your heart rate, is you're yanking on the tear. So we want to decrease the heart rate as well. So Esmelon will give us both control. So that's why it's preferred. Labetalol would be great because it does really good job on both, but it's so long acting that it could be dangerous. It's actually a great drug, but the other disadvantage with labetalol is it's a little harder to. There's a little bit more complications. It doesn't come prepackaged in a bag. It has to be mixed by pharmacy. Comes in a glass vial. There's just those limitations as well, but also the fact that labetalol is a lot longer acting. Esmelon is short acting, so if you end up converting where that tear ruptures or you get, patient gets hypotensive, you can turn it off and not be in trouble. The reason why it's preferred over just like a nicardipine or something that's pure blood pressure control is that it actually also controls the heart rate. So you will sometimes use it in conjunction with nicardipine. You may actually end up with a patient where you can get some heart rate control, but you max out on Esmelon and you still haven't gotten blood pressure control. So in that case, you might actually add nicardipine to it to get some better blood pressure control. But nicardipine can actually cause like a reflex tachycardia sometimes. It's been described, which would be a real problem. So if we start nicardipine without giving any kind of beta blocker, there's a chance, it's a pretty slim chance, but there's a chance that you could cause tachycardia, which does the opposite of what you want to do. All right, so diltiazem. So now we're switching categories. It's still drugs that are going to slow our heart rate. Diltiazem is what's the mechanism of diltiazem?
That is a calcium channel blocker.
Exactly. So it blocks the calcium channels in our heart, which causes slow conduction. Right, calcium is very instrumental in the conduction pathways in your heart. So it slows conduction. It also slows the squeeze. So this is actually going to be a negative inotrope as well as a negative chronotrope. So we use this for narrow complex tachycardias. You guys carry this in the field already. This would be a go-to drug for AFib with RVR. It's used for rate control. So this is going to be given as a bolus dose as well. You give the loading dose, and then typically you start them on a drip as well. So loading dose is 0.25 milligrams per kilo, and then you give that over 2 minutes. You can repeat that at a little bit higher dose, 0.35 milligrams per kilogram, and then you start an infusion at 5. This is a little bit longer duration, 3 to 4 hours. so sort of in the middle there, right? And you want to be careful. Obviously, if patient's in shock already, you don't want to give this drug. It's going to further exacerbate those problems. Use caution when you're giving a conjunction with a beta blocker, because you could have compounding effects. And then if you got a Wolff-Parkinson-White syndrome, you want to avoid diltiazem. And then we have amiodarone. So amiodarone is a little bit of a different beast, right? This does control heart rate, but it does so in a different way. This basically sort of resets the heart. It's almost like, the way we shock a patient and sort of allows for a refractory period and allows for the patient's heart to kind of reset itself. Amiodarone does the same thing, but it does it chemically. So it inhibits, it affects your calcium channels, your potassium channels, your sodium channels, all the channels, that are effective in your electrical system of the heart. It basically blocks those and allows basically things to reset, right? So amiodarone doesn't directly, usually it can lower your heart rate, but really more what it's doing is it's a dysrhythmic agent. So if your patient is in AFib RVR, so their heart rate is increased because they're in atrial fib, it's going to convert the patient out of atrial fibrillation into a sinus rhythm. So this is more of an antiarrhythmic than a true, heart rate control. It controls heart rate by putting you in a normal rhythm. So this wouldn't be effective in a patient with sinus tachycardia, right? It would only be effective in a patient that had a dysrhythmia causing their heart rate. Why? So this you guys give in the field, but you don't give it for AFib, right? What do you give this for?
VTAC, SVT.
Yep, VTAC. And you're going to give that sort of at a higher bolus, right? So if you don't have a pulse, you're in cardiac arrest, you give it for VTAC without a pulse, you give 300 milligrams IV push, right? If they have a pulse, you give 150 bolus, right? Typically, once you give the 150 bolus, you then start them on a drip. I don't know if you guys do that. I don't think you guys usually start them in the field on a drip. But you would give the bolus, and then when they got to the hospital, we'd start them on a drip, right? So that drip is like a maintenance dose. It's 1 milligram per hour for the first 6 hours, and then you decrease it to 0.5 milligrams per hour. So this really is an anti-dysrhythmic. The uses for it range from VTAC, pulseless and pulse VTAC. We give it for VFib, and then we'd also give it for AFib RVR, right? Now, why do you think that your protocols, your Maryland protocols, don't allow you to give amiodarone for AFib with RVR? They only allow it for these lethal rhythms. Why do you think that is? Your first line for AFib RVR would actually be diltiazem, right? Why do you think that is?
It is a longer duration, causing a longer hospital stay.
What, amiodarone?
Yeah.
Yeah, yep, it is going to be longer duration, and you'll have to put them on some kind of maintenance. That's one thing. There's another reason though. So the goal for amiodarone is actually to convert the rhythm, right? The goal for diltiazem is actually just to slow the heart rate down, right? And that's actually important because what risk do you have when you convert when you have somebody in AFib? What is the risk that they're going to develop? What might they develop if they stay in AFib for a while?
They might develop a blood clot, get a stroke.
Exactly. They develop blood clots in their atrium because their atrium is not really, the blood's not really pumping through their atrium. It's just kind of stagnant there. So it develops coagulation. So yeah, so it could potentially go to stroke, but while they're in AFib, it doesn't cause too many problems because it's all just staying up in the atrium. But if you were to then convert that patient to a sinus rhythm, what happens to those blood clots? Now they're shooting out, right? Now you've started to squeeze the blood. You're shooting those clots out to the body, up to the brain, causing a stroke, into the coronary arteries, wherever. You're going to cause problems. So in the field, we don't really know how long the patient's been in AFib most of the time. So we would rather just control their heart rate until we can get an echo and see if they have any blood clots in their atrium. So typically, if you don't know, if the patient's been in AFib for longer than 24 hours, you need to get an echo before you try to convert them into a sinus rhythm. So in the field, usually that's unknown. So we would consider that, potentially greater than 24 hours. So that's why you would choose rate control over a dysrhythmic to convert the rhythm. So some of the things that can cause by side effects is you can actually cause some pro-arrhythmic events. Like this has so many effects on all your calcium channels and all your different action potentials that you can cause pro-arrhythmia events. You can cause bradycardia and hypotension, and down the road it can cause liver function failure as well. So you got to kind of keep an eye on all those things. The most common that I've seen, I've never seen pro-arrhythmic events. The only thing I've really seen as far as side effects are bradycardia and hypotension. Definitely seen both of those things. Those would be the most common. All right. So that does our heart rate and our cardiac output. We'll get into stroke volume. Do you guys want to take like a little bit of a break? Going for almost an hour. Take about 10 minutes. Come back at 9:30. Sound good? All right.
Sounds good. Thanks.
Yep. All right. Well, we will get started again. Share my screen. All right. Can you guys see the screen? Everybody back?
Yes.
All right, so now we'll get into the next sort of phase of our cardiac output and things that affected, and that would be stroke volume. And then within stroke volume, you have preload, contractility, and afterload are all things that affect it. So we're going to start off with contractility, discuss that. So how do we measure it first? So one way, there's multiple ways here, but the main ways that we would measure stroke volume would be ejection fraction. So that's why you guys are probably familiar with seeing reports from echo about patients' ejection fraction measured in a percentage. So it should be over 40%, usually in the 40 to 60% range would be normal. And then as we get down below, into the 30 range, 20, then we're starting to get, pretty low. And then stroke volume itself can be measured using a PA catheter or some of the other cardiac output catheters that we mentioned before. And the normal range for your stroke volume is 55 to 100 mLs. So think about that. Write that down as a measure to remember. 55 to 100, and then you have a stroke index, just like you had a cardiac output index. You can do the same thing with your stroke volume. So that would be stroke volume divided by your body surface area. For some reason, I'm not really sure why, but for some reason stroke index is not reported as often as your cardiac output. So typically you're looking at your total stroke volume and then maybe looking at your cardiac index. So those are your main measures for contractility. The things that sort of affects your contractility, you have three phases of your heart, or three different sort of aspects. Your total inotropic effect, and that's how strong the contraction is. That's the squeeze, right? And then you have chronotropic, which we talked about with our heart rate. So that's increasing the rate. And then dromotropic effects, which affects the speed of the conduction in your vessel. So we're going to talk mostly about inotropic, but a lot of our agents actually affect all three of those. So if we have a patient that has low contractility, these are our heart failure patients, things like that, right? So if they're low, basically that's what we're treating. We're not usually treating high contractility. We're typically treating patients with low contractility. And we have basically two main options. We can do inotropic support, which would be drugs that cause increased squeeze. And we can do mechanical support, right? So mechanical support would be your balloon pumps, your Impellas, and your ECMOs. Now, the nice thing about mechanical support often is a good choice for these patients because these actually support the heart without causing an increased workload of the heart, right? So it doesn't put more stress on the heart. It just relieves the heart of stress. So most of the time, the patients that are in severe failure or really have issues here, we might put them on inotropes at the beginning, but we also might put them on inotropes to bridge them to mechanical support. So sometimes they're getting both. So the big drug that we talk about and we think about when we think about inotropic support is dobutamine, right? We already talked about dopamine. Dopamine does have an inotropic effect, but it also has all these other effects, right? So dopamine is a drug that it's not a vasopressor. In fact, it's actually a vasodilator. So dopamine works on beta-1 receptors to increase the cardiac output. So it causes increased contractility, but it also works on systemic vasculature. It causes vasodilation. So this is actually, we'll talk about afterload, in a minute, but this has a nice effect of increasing the contractility, but actually decreasing afterload. So it makes it easier for the heart to pump because the vasculature is not super clamped down, right? So it vasodilates and causes that. This is used in decompensated heart failure patients. Your normal dosing range is anywhere from 2 to 25 mics per kilo. And the titration of this is a little bit different than the rest of your pressors. So most of our pressors are going to be, they're going to go in as orders. They're going to be titrated based on sort of your physiological parameters, usually your MAP, right? So you'll get an order for Levophed or for dopamine, and it'll say titrate to a MAP of 65, right? And it'll give you all the titration parameters. With dobutamine, it's not quite that simple because you're really titrating more to cardiac output. So typically dobutamine is more of a tightly controlled, there's not as many titration parameters. Typically, you're going to be titrating it per physician order directly, at least at Hopkins. So that's just one thing. We're not usually titrating dobutamine quite as much. Dobutamine will can sometimes cause arrhythmias and tachycardia and tachyarrhythmias as well, particularly if your patient is hypovolemic. So one thing that's really important with dobutamine is it's going to increase the squeeze of the heart, right? But we have to make sure that there's something inside that vessel or inside that chamber to squeeze against, right? So if your patient's hypovolemic, it's going to increase the squeeze, but it's not going to increase the cardiac output because there's nothing in the tank, right? So we got to make sure that there's adequate fluid resuscitation or adequate fluid volume whenever we're working with dopamine. So that's a big thing. It does cause increased O2 demand on the heart because we're causing the heart to squeeze harder, which increases the O2 demand. So once again, just like dobutamine, we sort of have to be careful about that, making sure the heart can handle that increased O2 demand. But it's not nearly as bad as dobutamine because it doesn't cause as much tachycardia. And it also, like I said, causes vasodilation. So that eases the workload of the heart. So what you'll actually see oftentimes with dobutamine is actually a decreased systolic blood pressure, but an increased MAP because we're vasodilating. So it's decreasing the systolic, but it's also increasing the squeeze. So overall, we're getting better perfusion, right? Any questions or thoughts with dobutamine? And then we have milrinone, which is a very similar drug to dobutamine. The difference is milrinone's a little bit longer acting. So you see the duration is 2 to 3 hours versus 2 minutes with dobutamine. So typically dobutamine is used sort of in the acute event, in the acute phase, as we're trying to get a handle on our patient and things like that, and then maybe transitioned over to milrinone, as they're becoming more stable and maybe even going home. We actually take patients home on milrinone a fair amount because they need that additional support to treat their heart failure. So we'll see this a lot in the PCU, especially as patients are on this kind of more long term. All right, any questions on contractility? All right, we'll talk about preload now. So preload is basically think about volume, right? So preload, the definition is the amount of stretch of the ventricle at the end of diastole. So after fluid has filled into the ventricle, how much that ventricle is stretched out and filled up with fluid. So basically, when you think of preload, think of volume. Think of your volume status. Think of that. It's going to be affected by how much intravascular volume you have and also your venous tone, right? So if you have low volume in the tank, patient's hypovolemic, that's going to cause a low preload. And same as if you all of a sudden vasodilate everything and don't change the volume, again, you're going to have low pressures and low preload. So when you talk about preload, often talk about Frank Starling's law, which basically says the more you stretch the cardiac fibers, the more forceful the contraction is, right? So that's one way that we can manipulate and help with cardiac output is by stretching those fibers more, we get better squeeze and better cardiac output, right? Just like a rubber band, as you pull it back further, it snaps back a little harder. So that's Frank Starling's law. And then the second part to it is basically the more you stretch, the harder the squeeze until you overstretch, right? So you can get to a point where you overstretch the fibers and you no longer get very good squeeze because just like the rubber band, you pulled it too far and now it's floppy, right? So what that means for us is basically as we're manipulating preload by giving volume, we want to be monitoring the patient to make sure that we are not getting to the point where we've overdone the fluid, right? And basically, how do you do that? I mean, how do you know if you're fluid resuscitating somebody, how do you know you've gotten to the point where you're no longer being effective, you've gotten to the top of that Starling curve, and you're no longer causing any increase in cardiac output? How do you know when you've gotten there? It's actually simple, right? You give fluid, what do you want to see? What do you want to see happen once you give fluid?
You don't see what you're looking to see. So if you're looking to see an increase in blood pressure, you're not seeing it.
Exactly. So you give the first liter and you get a bump in your blood pressure and you're like, all right, sweet. Then you give the second liter and you don't really see any effect, right? Well, now you're probably thinking, okay, that we're probably tapped out. We don't need to give them any more fluid. So it's you basically just you're doing your intervention. You're going back to basics. You're doing your intervention, and then you're reassessing. Did you see the result that you expected? And once you're not seeing the result anymore, then you might think stop doing that. So move on to something different. All right, so our preload, is measured by our CVP. Typically, that's going to be the most common measurement that we're going to use to really get a numerical value for our preload. The CVP actually directly measures the right side of the heart, because the catheter sits right here in the vena cava, right? And so it measures as fluid backs up from the right side of the heart. It measures the pressure there. You can also use a wedge pressure from a PA catheter, and that measures the left side of the heart. Typically, we don't have access to, it's not real common that we have PA catheters inserted. So mostly we're using the CVP to do that. So if we have a decreased preload, we're really thinking hypovolemia or fluid loss, right? Which causes hypovolemia. So hypovolemia is what we're thinking. Means they need fluid. They have a decreased preload, they need fluid. If we have an increased preload, we're thinking of something that is affecting the pump, right? Or it's affecting too much volume. So either we have volume overload, we've given them too much fluid and overdone it, or something's happening with the heart itself to not allow it to pump effectively, and we're getting back fluid backed up. So basically, the way we mostly manipulate preload, if we have a low preload, we're going to give fluid, right? We're going to give volume, and we have a couple choices. Do we give crystalloid, do we give colloid, or do we give blood products, right? So crystalloid is usually our first go-to. It's the most readily available. We can give that quickly and have access to it. Colloids, albumin is the most common colloid we would give. And the idea with colloids is you're giving a smaller volume, but it's a bigger molecule. So basically the albumin goes into the blood vessel and fills it up with this big molecule, which then causes the osmosis to pull fluid from the interstitial spaces, right? So fluid is being pulled in from the tissues into the vasculature. So this is good for patients that maybe have been in the ICU for a while. They've got all kinds of edema. Oftentimes we might give them albumin for that. And then blood products. When do we need to give blood products?
When you need to replace, the circulating volume. So if they've lost too much blood, then you need to replace, or if you need to replace platelets or, RBCs. I guess it depends on what you want to achieve.
Yeah. So the key there is what you said at the beginning, like it's to replace. If they're losing blood, if they're bleeding, you need to give them blood, right? So that's the challenge that we have, like sort of in the trauma environment, like sort of pre-hospitally, especially, is that they're losing blood, they're hypovolemic, they're in hypovolemic shock, but all you have to give them is crystalloid, right? Sometimes you got to do what you got to do, but you're not really, all you're doing is expanding the volume. But if they're losing that blood, you're just diluting the volume down. So really what you want to give in a bleeding patient is blood, right? So anytime they're bleeding, always be trying to get blood for that patient. And then high preload, these patients we're going to give, there's actually a couple things we could give. We could give diuretics to get rid of some of that volume. We could give venodilators to sort of just accommodate the volume. And actually one thing I didn't put on here is also inotropes. An inotropic medication will help to decrease preload by moving that fluid forward potentially. Anytime we're talking about preload and especially volume, we want to be targeted about it, right? We always want to have a goal in mind. What are we trying to achieve? So it can be a little bit challenging actually with fluid management of what the goal is we're looking for. Of course, we have blood pressure effect. That's one thing that we look at. Are we getting the blood pressure response we want to see? But then CVP is another thing to monitor. The challenge with CVP is that there's a lot of factors that affect your CVP, the numbers itself. So if you have somebody on the ventilator, they're automatically going to have some higher CVPs because you've got that intrathoracic pressure increase. If you have, there's all kinds of things that affect it. Just different people have different pressures. And you'll even see that if you look up what is a normal CVP, you'll get all kinds of different ranges, right? You might see 2 to 6, you might see 4 to 6, you might see 4 to 8, all these different things. So it can be challenging to know exactly what normal is for a CVP. So getting one measure of a CVP is only limited helpfulness. Really what you want to see with CVP is trends. You look at trends with CVP. So if you're fluid resuscitating a patient and you have a CVP, you can look, what was the CVP before I gave the fluid, and did it increase once I gave the fluid? But shooting for a specific number is not always most helpful, right? It used to be like in our sepsis guidelines, we would say fluid resuscitate to a CVP of, I think it was 12 or 10, but that's no longer really the case because there's so many other factors. So you just want to see a response. We basically want to, thinking back to the Frank Starling law, we want to make sure that when we're giving fluid, it's being effective. So basically the easiest way to do that is this fluid challenge, right? We give the fluid and we see if it worked. If it didn't work, we'll probably move on to other mechanisms, whether it's pressors or whatever. But did the fluid improve the blood pressure? There's some other ways to measure sort of if the patient needs volume. So the question is, does the patient need volume or they need vasoconstriction, right? That's kind of the two things you're thinking of. So one thing that you can do actually that's pretty cool with the flow track is actually measure what's called stroke volume variation. And so it's a percentage. And what it's measuring is on every beat, how much volume is being ejected out and how much variation is there from beat to beat. So if you have a patient that's got a lot of fluid, that's adequately resuscitated and has good fluid status, then you're going to get very consistent stroke volumes. Every beat is going to be consistently pretty close to the last beat. If you're getting 75 mLs out, you'll get 75 mLs out with every beat. As your patient starts to get dry, there becomes more variation from beat to beat. So that's the increase in variation. So anything greater than 13% variation between beats kind of tells you that your patient's dry and you need to give some fluid. So that's a nice thing that you can see with the flow track, gives you that information. The challenge is you might not have a flow track, or if your patient has irregular heart rate, that's going to change it too. So you can't really use it too well in the irregular heart rate patient. But if they have a steady heart rate, you can use that. And then passive leg raise. Anybody here use the passive leg raise technique? This is really cool. I like to use this sort of as I'm trying to determine, does my patient need fluid or not? It can be used. It's ideal if you have an A-line, but you don't need an A-line. You can do it with a blood pressure cuff. Basically, what you do is you lay your patient flat, and then you raise their legs 45 degrees, right? And then what happens to all the blood that's in the legs there once you raise it? It all rushes, all rushes back to the heart, right? So basically you're giving that patient like a 250 cc bolus of their own blood, essentially, right? So what you want to see then is you want to look at the effect. So you see when I raise his legs up, does the heart rate come down and does the blood pressure go up, right? So if I see the heart rate comes down, blood pressure goes up, I know this patient is fluid responsive and they probably need a little bit of fluid. I can give them some fluid, right? If they're not fluid responsive, then I know, okay, it's not a fluid issue. I'll start looking in other ways. So it's pretty cool, easy, quick measurement. All right, now the third thing about stroke volume is your afterload. So afterload basically is the amount of work the heart has to do to pump the blood out, right? So and this is affected mostly by how constricted the blood vessels are. So if the blood vessels are very, very constricted, very tight, that's going to cause an increase in afterload. And if they're dilated, that's going to cause a decreased afterload, right? It makes sense. The larger volume you have, the easier it is to pump out the blood. So as you vasoconstrict, you increase the afterload. This is measured by what we call SVR, or systemic vascular resistance, right? And so the normal range of SVR is 800 to 1200 dynes per second, right? So if the patient has a higher SVR, that means they have a higher afterload, and it means their blood vessels are very vasoconstricted. If they have a low SVR, they have a low afterload, it means their blood vessels are dilated, right? So your body has basically two mechanisms to control SVR. And one would be on the left side of the screen here, you have activation of cytokinase. Cytokinase cause direct vasodilation. So as soon as those are affected, then they cause vasodilation. So cytokinase are activated in sepsis and in anaphylaxis, right? So allergic reactions and sepsis. These are ways. They're also released in sort of normal scenarios too to vasodilate, but in those two conditions, we'll see a lot of activation of cytokinase, which causes direct dilation. And then it also causes some decrease in the sphincter tone, which causes, again, more dilation and a decreasing of the length of the vasculature. So it really causes a lot of vasodilation, like just generally all over your body, and which reduces afterload significantly. So if it happens too much, this is where we get into our issues with distributive shock, right? If this is sort of overblown, then we have a distributive shock scenario where we've got widespread vasodilation, and we need to cause vasoconstriction, and we need to give volume. On the other side, you have the mechanisms that the body uses to cause vasoconstriction, which increase afterload. So we have the sympathetic nervous system does it directly by releasing epinephrine and norepinephrine and all these things we talked about before, causes vasoconstriction, which increases the afterload, right? And it also activates the renin aldosterone angiotensin system, which causes more of a long-term effect and a more delayed response, but more of a long-term response. So what do we do to manipulate this, right? So if we have low afterload, like in the case where I mentioned sepsis or anaphylaxis, we're going to want to do two things. We want to give vasopressors to vasoconstrict, and we want to give volume to fill up the space, right? If we have high afterload, patients just really clamp down and causing issues with the heart not being able to adequately pump against it, then we need to give something to reduce the afterload. So we might give arterial dilators, which would be some of the things we talked about before, like your we'll talk about that later, but nicardipine, things like that to vasodilate. Calcium channel blockers also vasodilate. Your ACE inhibitors, that's going to be, again, your long-term patients. You're not giving that in an acute environment, but that interrupts this renin aldosterone angiotensin system here. And then a direct alpha adrenergic blockers. So a lot of the blood pressure meds that people take are direct alpha adrenergic blockers, cause vasodilation. All right, so starting on our pressor side, norepinephrine. So norepinephrine, this drug you should know inside and out. This is our first line pressor. We use this all the time. You guys are probably very familiar transporting patients on this. Norepinephrine is a alpha-1 and beta-1 agonist. So this causes vasoconstriction, but it also causes a little bit of increased heart rate and increased contractility. And this sort of is the opposite side of dopamine. This has much stronger vasoconstriction properties than it does with tachycardia. So that makes this a very nice drug for first-line pressors, because it really does cause nice vasoconstriction without jacking up the heart rate through the roof. Your dosing for this can be anywhere from 0.01 to 3 mics per kilo. Usually we start this, our starting dose is usually 0.05, and we'll titrate by 0.05 every 3 minutes or something like that. It's got a short duration. So you guys have probably seen this in action. You're in CT and all of a sudden you hear the pump alarming, right? And the blood pressure falls pretty rapidly after that, right? It doesn't, you gotta keep an eye on it, because if there's interruptions, the patient's gonna drop their blood pressure pretty quickly. This also is a vesicant, so you have to monitor for infiltration and extravasation. If it gets into the tissues, it's definitely going to cause tissue necrosis. You can give this also peripherally, you can give it centrally, you can give it through an IO, right? Obviously, our preference is always to give it centrally if we have that option, but certainly can give it peripherally in a pinch. It can also cause arrhythmias, but not nearly, it doesn't cause it nearly as much as like dopamine does. So much less effect on that. There used to be people called Levophed, leave them dead. There used to be sort of a bad rap for Levophed. What was happening is I think people were using it at too high doses for too long. And because it is such a strong vasoconstrictor, you're actually doing what I said in the beginning. You're causing pretty numbers, but actually decreasing perfusion. So you just got to be careful and monitor sort of the other signs. Make sure you're actually increasing perfusion and not just totally vasoconstricting everybody. So this is typically going to be our first line pressor. Oops. Epinephrine. Epinephrine is the big guns here, right? So epinephrine causes alpha 1 receptors activate, beta 1, beta 2, all your receptors. So it causes very strong effects on all your receptors. So it's going to cause strong vasoconstriction. It's going to be a strong inotrope, as well as increasing your heart rate. And it's also going to be a strong beta 2 agonist, which causes bronchodilation. So this typically, if we're giving it to like a septic patient or a cardiac patient, you know, we're giving this as like a second line pressor or a third line pressor even sometimes, right? Because it's such a strong agent that we want to sort of reserve this for those more challenging patients. What patients would this be kind of your first go-to? Especially for that bronchodilation effects.
Asthmatic.
Maybe,
Yeah, so asthmatics, you would give this to, right, for that bronchodilation, and also anaphylaxis. This would be kind of your first. You would obviously be giving usually sub-Q first, but you could put them on a drip as well. This is typically going to be your second line when it comes to cardiac patients. Oftentimes, this is going to be your second line pressor. So you might start off with Levophed or dopamine even, and then you would move to epinephrine because it's got such a strong inotropic effect. So if you're transporting a patient, they're on a balloon pump, you know their cardiac output is terrible. You know, be thinking down the road, I might have to start an epi drip. And then also with your asthmatics or your anaphylaxis patient, this is going to be a go-to as well. Some of the problems or some of the side effects, it causes all kinds of tachycardias and it stimulates everything, right? You can end up with some hyperglycemia or hypoglycemia. It's really changing up the metabolic demands of the body, so you can get all kinds of fluctuations with your electrolytes and with your glucose and things like that. So you got to keep an eye on that. It also is very quick acting and lasts only a couple minutes. So if you've got a patient on an epi drip, you want to definitely be closely monitoring that drip. Make sure you don't run out or pause it. All right, and then phenylephrine. Phenylephrine is pure alpha agonist. All right, so it only causes vasoconstriction. It doesn't do anything to the heart. Doesn't stimulate the heart at all, right? And actually, what you can see with phenylephrine is you can actually get a reflex bradycardia because the body all of a sudden senses a change in blood pressure, and you've got your baroreceptors in your carotid arteries that measures the change and sends a signal to your heart to say, why don't you slow down, because we've all of a sudden had an increased blood pressure, right? So you got to be a little bit careful with phenylephrine since it doesn't stimulate the heart at all. Sometimes you'll get sort of this reflex bradycardia. This typically is not used as your first line most of the time because it's actually usually Levophed is better because it does give that little bit of cardiac stimulation along with the vasoconstriction, which is usually what you want. This is used in scenarios. Anesthesia uses phenylephrine a lot. and it's a good drug for them because one of the main reasons they deal with hypotension is because all the drugs, all the anesthetics they give, it cause vasodilation, right? So they give all this medication to put the patient to sleep, which causes all this vasodilation, and then they hit them with a little bit of phenylephrine to sort of reverse that vasodilation. So it's kind of like a, they're just managing the side effects of the other drugs with the phenylephrine. But for patients that are septic or patients, that we're dealing with, usually Levophed is going to be a better first line. Vasopressin. Vasopressin is an endogenous hormone secreted by your pituitary gland. And this also causes peripheral vasoconstriction. Vasopressin is often used as a second line option, pressor option for septic patients. Works very well in septic patients because of the pure vasodilation or vasoconstriction, right? It also works pretty well in acidic environments. So it works very synergistically with Levophed. So oftentimes, just like I said with the cardiac patients, epinephrine tends to be your second line pressor. In your septic patients, typically you start with Levophed, and vasopressin would be your second line pressor for this. It does cause you have to sort of watch and monitor for peripheral vasoconstriction issues, and also causes a lot of GI. If you leave somebody on vasopressin too long, it can cause a lot of GI ischemia as well, because it really has a lot of vasoconstriction effects in the GI tract. So you got to be careful and take a close look at that. Since it does have such an effect in the GI system, there's another use that you can use it for. You can actually use it for somebody who has variceal bleeds, so high esophageal bleeds, usually your alcoholic patients that are bleeding upper GI bleeds. You can use high dose vasopressin, and the theory is that you vasoconstrict those vessels so much you sort of clamp them off. So that can be used for that. The typical dosing for vasopressin is 0.03 to 0.04 units per minute. And that's just usually left on constant. So you're not really titrating this drug. You put it on at 0.04 or 0.03 and you leave it there. You're not titrating up and down.
I have a question about that.
Yeah.
I noticed that the CCU is one of the places that is, and the cardiac surgical ICU are starting to actually titrate that.
Oh, interesting.
Which I always knew it was like 0.02 or 0.04 and off, but yeah, they were saying that they're starting to titrate that. So I just didn't know what the
Parameters.
or like, what's the point of that, I guess.
Yeah.
I don't know.
That's a good question. I'll have to follow up. I didn't realize that. So it's been my practice as well. That's pretty stable dosing. So I'll follow up with that, find out for you. You can also use it when you're using it for variceal hemorrhages. It's a different dosing regimen. It's also a different dosing regimen when you're using it for diabetes insipidus. So in addition to causing vasoconstriction, it's also antidiuretic hormone, stimulates antidiuretic hormone release. So it causes your patients with head trauma that go into diabetes insipidus and just start dumping volume. This will cause them to retain the volume. So you might see it in those patients as well. And again, it's a different dosing for that. All right, so now switching gears, now we're going to patients that we want to vasodilate, right? So all those were vasoconstrictors. Now we're going to vasodilate. So first is nitroprusside. Nitroprusside is both a venous and an arterial dilator. So it's going to decrease afterload, decrease SVR, and it really causes overall decrease afterload. This is used primarily in your decompensated heart failure patients to reduce afterload and help them pump more effectively. This drug, the advantage of it is it's purely a vasodilator. It does not depress the actual cardiac function at all. So we'll talk about some of the other things, but it doesn't have any negative inotropic effect. So it leaves the heart alone, and it decreases the SVR and allows the heart to pump a little more effectively. probably one of the issues with this is that for long-term use, you can cause all kinds of toxicities. So you need to monitor for cyanide toxicity and other issues, and renal and hepatic failure as well. So this is something that would have to be monitored in our environment. If we were to start this, it's not something we'd have to worry about on the acute phase. It's something that you have to worry about later on. And then nicardipine. This is probably one of our most familiar agents for reducing blood pressure. This is a calcium channel blocker. So it inhibits cardiac smooth muscle as well as vascular smooth muscle. So it's going to cause vasodilation, but it's also going to be a negative inotrope. So it's going to decrease your heart rate or your inotropic effect a little bit. So this is why this is not usually used in cardiac patients as much, because it does have that inotropic effect. This is definitely first line for patients with head bleeds that we're trying to manage, or other things that are not cardiac related. Dosing for this is typically starting at 5 milligrams per hour, and then you titrate by 0.5 milligrams every 15 minutes, up to a max of 15 milligrams per hour. Like I said before, when we were talking about aortic dissections, you can get a reflex tachycardia with nicardipine. So you have to watch that and take a look at that. All right, we're going to skip, we'll skip pulmonary vascular. So this is a nice just summary slide, talks about some of the pressors we discussed and splits up the 3 different effects that it has: inotropic effect, heart rate, and SVR. So you can see adrenaline, which is epinephrine, has high effects across the board, right? Norepinephrine, moderate inotropic effect, but high increased vasoconstriction, right? Dopamine, high inotropy, high heart rate, and moderate to high SVR. So if we're monitoring, if we're managing somebody's blood pressure, normally these patients have A lines in. We transport a lot of patients with A lines. That's something that also will, be in your scope of practice for the in-house side of things, is managing the A lines. So a couple of things that we want to discuss just to sort of get everybody on the same page with is how to monitor an A line, how to assess it, right? So the first thing is the transducer. So we got to make sure that the transducer is in the correct place. Otherwise, we're going to get an inaccurate blood pressure reading. So the correct place is at the phlebostatic axis, which would be 4th intercostal space, mid-axillary line. So you can see on this picture, the mid-axillary line is here. It's not actually mid-thoracic. There's 2 different things. So a lot of times people actually mistake the mid axillary for mid-thoracic. So it's actually you gotta draw that line down their axilla, and it's a little bit lower than their mid-thoracic line. It's important to kind of monitor this as you move your patient. We've all seen this. We go to CT scan, we put their arms above their head, and all of a sudden we get these wacky readings, right? It's because we've moved the transducer, and so we're not getting an accurate reading anymore. There are basically 2 ways to placement for this. At Hopkins, we tend to put the transducers on the arm, which is nice. It generally keeps them basically in the correct position. But like I said, as you're moving the arm around, you might get some erroneous results. The other way, the other placement would be to place it on an IV pole, and you would actually level it. You can get a little bit more accurate placement that way. But every time you sit the patient up or you lower the bed, you'd have to change the transducer. So you got to be careful with that. But like I said, usually around here, we're putting it on the arm. If you put your transducer too low, if it falls off the arm and it's laying on the floor, you're going to get a falsely elevated blood pressure. And if the transducer is too high, you're going to get a falsely low blood pressure. And then we look at the waveforms. So here we have the normal waveform for an arterial line. This is your systolic pressure up here. This is your diastolic pressure. And this little bump here is your diacrotic notch, right, where the aortic valve closes. And then your mean arterial pressure is the calculation of all this space underneath the curve, right? Always remember that your mechanical follows your electrical. So your EKG, if you were to line them up, your blood pressure is going to be slightly behind your QRS complex because electrical activity moves faster than your mechanical reaction. All right, so how do we tell if the A-line is accurate? You guys who have been sort of doing these transports for a while have probably run into the situation where you walk into a patient's room, they've got a blood pressure cuff on, and they've got an A-line. They've got two drastically different readings, right? And then you ask, well, which pressure are we going by? And how do people normally choose which pressure they're going to use? What do you normally see?
You can do the square waveform test and see,
Yes.
you know, if it's false, false high, false low. You also can ask them what they've been titrating by.
Yeah, so that's the right answer, Bridget. The right answer is you want to investigate and see whether it's accurate or not. But I would say the most common way people choose is which number they like better. Right? So it's like, oh, we like the pressure on the blood pressure cuff, so we'll just go by that one, right? But that's not correct. So what Bridget said is the correct way. So here's the square waveform test, and what you do with this is you get everything ready and you flush the A-line. So usually it's either you pull the pigtail on the transducer or you squeeze the little buttons on the transducer and you cause a flush. And then you look at the monitor while you're flushing it, and what you want to see is a straight up line, straight across, straight down. You want to see a square waveform, hence the square waveform test. And then you want to see one or two sort of oscillations or whips that happen after that square waveform before it goes into the next arterial waveforms. So this picture here demonstrates what you want to see. So if you see this and you have the transducer leveled correctly, and you've zeroed the blood pressure, like those are all the troubleshooting techniques, right? Level the transducer, zero the transducer, and then do the square waveform test. If all those things are accurate, then you should trust your A-line, right? Whether you like the number or not. And then, but then some other things you might see. So these are the two waveforms that you would say these are potentially inaccurate. And that would be an overdampened waveform, gives you a falsely low BP. So in that case, you would have the square waveform, but you would have no oscillations, right? And you would see that in these patients. Typically, the reason for that is you've probably got an air bubble in your line somewhere, or you've got too much tubing on it to cause that over dampening. So what happens when you have air bubbles in the line is that little bubble actually compresses and absorbs some of the pressure, right? So now you're not getting an accurate transmission of the pressure to the transducer. So make sure you take a look at your line, make sure all the connections are tight, make sure there's no air bubbles and things like that. That'd be how you troubleshoot that. Oops. And then you can see an underdampened waveform. So you might have what I see this normally. You would see straight up, straight across, and straight down, but you would see multiple whips here, more than two. You see 5 or something like that. And then sometimes you actually see you might actually see little waveforms on the top of this as well. So it's overdampened. So one of the main causes with this would be you don't have enough fluid. Your bags run dry, right? So check in the pressure bag, make sure there's fluid in the line, and everything is pumped up correctly. All right, so that's your monitoring. All this stuff, some of these things, this is a lot of information today and a lot of things that we've gone over. So there's some things that you just want to kind of keep in mind. Some of these things you want to know, like the back of your hand, how to start levofed and titrate levofed. That's going to be something you want to make sure that you know and memorize and are able to do that quickly, knowing how to mix it up. It's something you want to be able to do off the back of your from the back of your mind, right? Just right there immediately. Other things you might want to use resources for, right? So all of us need to have resources. We can't remember everything. So a couple things that you might use for resources is, number one, you're going to be doing this all from the EPIC order. So this is one difference when it comes to our scope of practice. We're not operating by protocol. When we're in the hospital, we're operating under orders. So looking at the EPIC order, it'll tell you what the titration parameters are and what your goals are. So definitely, if you're transporting one of these patients, make sure you take a look at the orders to see where your goals are. In the Lifeline protocol, this is attached to the calendar invite, but I also sent it out via email. We have a nice chart in the protocol that has a whole bunch of different drugs. It tells you what the normal parameters are. It tells you what the titration parameters are. It tells you how to mix them up, right? So it's a really good resource to have and to look at, so you can figure these things out. And then we have the Kathy White Critical Care Handbook. Does everybody have one of those? If you don't have one, Phil, you don't have one, grab one from Ben. He's got more in his office. It's a really nice resource, and it has all kinds of stuff. It has lab resources, it has hemodynamic resources, it has medication resources. Really good resource book. I use Medscape a lot personally. It's got a nice app. It's free to use. Create an account. It's a good resource to use for drug information. And then Micromedics also, we have them installed on the iPads, so you can use that as well. And then just focusing on sort of your first line stuff, the things we use most commonly, being able to mix them, to titrate them, and initiate them. So epinephrine, norepinephrine, those are really kind of like the two you really want to focus on and make sure you have a pretty good knowledge and familiarity with. All right. So any questions we have you want to discuss? And we're going to get into some case studies, and then we'll be all done. All right, let's get into the case studies to see what you guys learned. All right, so Mr. Arnold is a 54-year-old male. He comes to the ED with crushing chest pain, status post, and MVA. Assessment shows that he's alert and oriented ×3, lungs are clear bilaterally, and he has bilateral chest rise. He's got a benign GI and GU exam, but he does have abrasions on his chest from his seatbelt. The EKG shows ST elevations in the anterior leads, and he's complaining of shortness of breath, chest pain at rest, dizziness, and diaphoresis. His vital signs are temperature of 36.4, heart rate of 120, respiratory rate of 22, blood pressure of 86/52, and a pulse ox of 92. So what are you thinking is going on? What are the potential things that might be going on with Mr. Arnold here?
Looks like he's got some hypotension. Possibly, if he's got some seatbelt sign, he could have possible cardiac tamponade. He could possibly have some other chest trauma. But basically, it looks like some sort of hypovolemic shock. His heart rate was what, 120, so he's probably compensating, and his stat's a little low. So I don't know. I would think I'm going to go with tamponade, but I don't know.
All right, so you've got a couple. So you identified this patient's in shock, right? And then we have potential. We have a couple different options for what kind of shock. So you said tamponade, which would be a cardiogenic shock, right? So you're thinking from the trauma, he's got the seatbelt signs, potentially causing cardiac tamponade. It's cardiogenic shock. All right, what else? You also mentioned potential hypovolemia, right? So he's a trauma patient. Anytime we got a trauma patient, we're thinking, yeah, he might be bleeding somewhere. So we got potential hypovolemic shock going on. What other thing could be causing his shock? Would also be cardiogenic shock. What's the other sort of differential here that might be happening? Step away from the trauma for a second and think about what other.
So like obstructive, you mean? Like a MI type thing?
Yeah. So this is one of those cases where you're trying to figure out chicken or egg, right? So this patient has he's complaining of chest pain. He's got some ST elevation in his anterior leads, and you've got to figure out does he have that elevation and chest pain because of the accident and he had direct trauma, to his heart, which is definitely a possibility, right? And that would lead to the tamponade that you were talking about, Bridget. Or did he have a heart attack and then he got into a crash, which happens too, right? So how are we going to sort of investigate this patient? So what does he need? How are you going to treat him? And how are you going to figure out what he needs?
I would get like an ultrasound to take a look at the heart, see if it's in tamponade or not.
Perfect. So you're going to take it. That's actually, so you're probably going to do a couple things. You're going to take a look at the heart. You also probably do like a fast exam to check for any other internal bleeding, right? So that's going to sort of eliminate a bunch of things at once. So we're going to look at, is he bleeding and is he in shock because of hypovolemia, or is he in shock because something's going on with his heart? So we can look and we can rule out the tamponade. So this patient doesn't have any bleeding and he does not have cardiac tamponade, but he does have a little bit of a hypoactivity in the anterior chest wall of the heart.
So you can also get labs, so your troponins and things like that. So
Yep. Yeah, and troponins are elevated, right? Now troponins would be elevated either way, whether it was a heart attack or the trauma, right? But he's got elevated troponins. So since he doesn't have tamponade and he's got the sort of hypoactivity of the heart wall, what are you thinking is actually the cause of his issues?
Probably in the anterior wall MI.
Anterior wall MI, right? So that's what this guy has, right? He actually had a heart attack and then got into an accident, right? So how do we treat his shock?
Well, first I would want probably send him to the cath lab, but for treating his shock, I would want a something that increases contractility of the heart.
Right, exactly. So you want an inotrope, right? So this guy, are you going to slam him with fluid? This is a trauma patient. Are you going to slam him with a ton of fluid?
I would not.
Yeah, not because of the heart, right? That's why it's important to figure out what's the cause of his shock. Because if we had just come in here and assumed he's bleeding to death, slam him with, get the rapid infuser, we're just going to overload his heart, right? And cause more problems. He's already probably in some failure. His pulse ox is 92. So we're just going to probably make that worse if we give him more fluid, right? So you're exactly right. We're going to give him, we want to treat the cause. So you always want to be thinking about what is the cause? How do we ultimately treat it? So like you said, we're going to be trying to get this guy to the cath lab, right? And that's the ultimate way that we're going to fix him. So in the meantime, while we get him to the cath lab, we might put him on something that's going to have an inotropic effect. What do you think would be your choice here?
For some reason, I'm thinking dobutamine, but
Yeah, I think that'd be a great choice, right? Because that's going to cause. I mean, he's got a low systolic, but his map's still okay. We could probably, as we open up his blood vessels and we give him some inotropic effect, we'll probably actually get an increase in his especially his map, right? And it's gonna help us out. It's gonna give us that inotropic effect. Dobutamine would be another choice, but with a heart rate of 120 already, that would be a challenge, right? The other thing I would look at is, just continue to monitor his fluid status. Maybe he does need a little bit of volume. So giving volume in addition to the dobutamine might be helpful. You still might be able to give fluid. Just because somebody is in cardiogenic shock doesn't mean you don't give fluid. It just means that you're going to be careful with it and kind of be monitoring that. So I'd start him with dobutamine and kind of manage that, see if I need to give him a little fluid along with that. So he does go to the cath lab. He has a CVP of 16, SVR of 1800, and a cardiac index of 1.8. So what is abnormal, those numbers? This is before they fixed anything.
CVP, SVR.
CVP is high, right? So he's got a high
Mhm.
preload. SVR is high. So what does that mean about his blood vessels?
That they are clamped.
Vasoconstricted, exactly. Yep.
Yeah.
And his cardiac index is low, right? So I think that, you know, you were able to figure that out, that he needed dobutamine even before you got these numbers, right? So this is an important point too, is doing a good assessment and doing a good differential. You can figure out what your patient needs, and then they're confirmed by the more advanced hemodynamic numbering. So this would be great. We give dobutamine. We're gonna dilate his SVR, right? We're gonna vasodilate. So this is gonna go down. We're gonna increase his cardiac index, right? And then that's gonna help decrease his CVP as well, because we're pumping that fluid out. Beautiful. Nice job. Any questions on that case? All right, so next one, Mrs. Burke is a 70-year-old female admitted to the CV-SICU post-op mitral valve replacement. She is now starting to rewarm. So they cool people down for heart surgery a lot of times. So now she's starting to rewarm, and she's currently not on any drips, but here are her first set of vitals. She's got a temperature of 33.4, heart rate of 65, blood pressure of 110/60, respirations of 12, pulse ox of 96, and a CVP of 4. What are you thinking about her? Are you comfortable with everything? Are you concerned? What do you think?
Cold.
What's that, Eric?
She's cold.
She's cold. Yeah, so she is cold, right? And then, so how does that, and we're starting to rewarm her. So how is that going to affect the rest of her vital signs here as she rewarms? So that's the key, is that she's rewarming. So right now, in and of itself, you know, we've got pretty normal vital signs, right? Heart rate's normal.
Switch.
What's that, Andrea?
I'm sorry.
Heart rate's normal, blood pressure looks pretty good, right? CVP is okay. So right now, in and of itself, it looks okay, right? But what happens as she rewarms? What's going to happen to her blood vessels specifically?
They're gonna start to open up and she's gonna drop.
Right, exactly. She's going to vasodilate, right? So as she vasodilates, you know, what's going to happen to her CVP is on the low side. What's going to happen to her CVP as she vasodilates more? It's going to drop, right? Like you said, Eric. And then what's going to happen to her blood pressure?
Same.
Gonna drop as well.
Right. So what does this patient still need?
I would say a vasoconstrictor. specifically.
Vasoconstrictor, potentially, right? But and what else? Why would she need a vasoconstrictor? Because what's the underlying cause, I guess, of the need for a vasoconstrictor?
The drop in SVR, I would say. But before that, I'm reconsidering. I would say she needs fluids first.
Hey,
probably.
there you go. Beautiful. She needs fluids, right? So she's probably vasoconstricted, you know, because she's cold and she's maintaining a CVP of 4, but really she's probably under resuscitated. So she's just gone through pretty major surgery, right? She got her mitral valve replaced. So what you would want to investigate is how much fluid did she lose? Does she need more volume? And not only fluid, but what might she specifically need? What kind of fluid might she specifically need? She's blood, right? She's potentially lost blood. So you'd want to find out, did she get blood in the OR? Does she need more blood? What was her estimated blood loss, right? Do we need to still give her blood? 100% right. So we might need some vasopressors too to help us keep up with it. But what she really needs is volume to refill all those vessels. So she actually had say you had a PA catheter. Here's what your numbers are. So you had a wedge pressure of 5, kind of goes along with the CVP of 4, right? She has a stroke volume of 50, SVR of 1920, cardiac output of 4, and index of 1.8. So what's her what's abnormal here that you're worried about? or maybe not abnormal, but you're worried about.
Her index is low.
Yeah, so right away, this is where we've got a nice use of our cardiac index, because she's actually got a normal cardiac output, but her index is low, right below 2. So we know that she's got a low index. What else? Her SVR is very elevated, so we know she's vasoconstricted, right? So it just confirms what we already knew, what we already figured out, that she's right now very, very vasoconstricted. And her wedge pressure, it goes along with her CVP, is kind of on the low side. And her stroke volume also, though it's normal, it's on the low end of normal, right? So like you said, we're going to give her fluid, and we're going to monitor that. All right, nice job. All right, so third patient here, Mrs. Andrews is 55-year-old. She's admitted to the CCU for chest pain, shortness of breath, and productive cough. She decompensates and gets intubated and put on a vent. She's been on the vent for 3 weeks, has had recurrent pneumonias. She's on CPN, Foley, CVP, and her vital signs are as follows. Heart rate of 110, respirations of 22, BP of 80/40, pulse ox of 93, and a temp of 38.9. So what do you think is going on with her? Septic shock, right? She's going into sepsis, right? How do you know that?
Her temp's high.
Low blood pressure, elevated temperature.
Yep. And she's got plenty of reasons to have sepsis, right? She's got all these invasive lines and all that stuff. So what would you expect her CVP to be? High or low? You don't have to give a number, just high or low. Yep. What about her SVR? Is it going to be high or low?
Low.
Low, right. She's going to be vasodilated because of sepsis. And then what's her cardiac output going to be? It could go either way. Sepsis, initially, a lot of times you have a high cardiac output as you're trying to, she's still able to compensate some. She can have a high cardiac output, and then it could later on drop to be low. So it could go in either direction. So how would you treat her? What's your treatment going to be?
Antibiotics.
Right. So great, Eric. So always be thinking about the causes, right? So we need to treat the infection, make sure she get antibiotics on board, and then also be thinking about what was the cause of it. Do we have an infected line that we need to get out and put a new one in? All those kinds of things. What else? How we treat her hemodynamics?
Fluids.
We're going to give fluid, so heavy fluid resuscitation, right? So in septic patients, you want to fill up the tank. You want to give a good deal of fluid, right? So typically you want to give at least 30 cc's per kilogram. So if the patient's 100 cc's or 100 kilograms, you're going to give her 3 liters of fluid as fast as you can, right? So pressure bagging that in. What else you can do? Say you're trying to get the fluids in, but she's still hypotensive.
Levofed.
Levofed, yeah, exactly. That's going to be your first choice, right? Given Levofed. So what would you, what do you think your starting dose of Levofed would be?
0.01.
You could start that. Usually
Or
we
go a little bit higher.
Yeah,
Or 0.03.
Yeah, we usually start at 0.05, but any of
0.05,
those
okay.
any of those would be correct. And then you would titrate up by 0.05, every few minutes. The one caveat to that is, you'll get used to this as you're titrating more, but that's the stepwise approach. And so for this patient that's got 80/40, that's not a terrible, probably a map of like 55. We want to get that up, but we can have some time. She's not like peri-arrest, right? But if you start to get the blood pressures in the 70s, that whole titrating by 0.05 every 5 minutes kind of goes out the window a little bit. At that point, I'm starting at a higher dose, and then I'll work my way down. So if this patient was more critical, I'd probably start at 0.5 instead of 0.05 or something like that. So those are your typical starting doses and titration parameters, but you have a little bit of leeway to do what you need to do. This is also where push dose epi comes into play. Now, we don't necessarily use that in the hospital as much, but especially on our ground transports, somebody that's peri-arrest, you can give them push dose epi to sort of get them sort of a stable blood pressure to give you time to titrate the pressors. All right, so we're going to give pressors, we're going to give fluid. Beautiful. What if this patient was a heart failure patient? How would that change? Do you still give fluids?
Would be more mindful of the fluids that we're giving her.
You would be more mindful. Would you still give the fluids?
Yes, but just check the lung sounds, and just be careful with it.
Exactly, 100%. Don't not give. Septic patient needs fluids, whether they got heart issues or not. So you just gotta watch it, right? And then what drug might you actually add on? You still start with the Levophed, right? Because they need vasoconstriction. But what might you add to that to help their heart function?
Dobutamine?
Yeah. So this would be a great patient that would have sort of a Levophed and dobutamine, right? And so the Levophed is causing some vasoconstriction. Dobutamine by itself wouldn't necessarily be great because that would just worsen the vasodilation that the patient has from the sepsis. So the Levophed will cause a little bit of vasoconstriction to counteract the sepsis, but then the dobutamine will help with the inotropic effect to really get that fluid moving, and you can then make sure you're giving fluid adequately and things like that. So, yep, nice. All right, last one. Mr. Thomas is a 24-year-old, multiple GSWs to his right chest and abdomen that damaged his liver and lung. He arrives to the ED. He's agitated, confused, and in pain. All right, so here's your, remember we talked about the neuro assessment and the perfusion, right? Here you go. There it is. He's agitated, confused, and in pain. What does that tell you about his perfusion?
Not good.
Yeah, poor, right. Always think about that. Whenever you have an agitated patient, there's so many reasons why a patient could be agitated. And don't forget about confusion, right? I mean, don't forget about perfusion, sorry, and oxygenation and all that stuff. So what do you think he needs, and what are his hemodynamics going to look like?
He needs blood.
Right. What's going on with him? He's bleeding, right?
He's hemorrhaging.
Yeah. So he's in hypovolemic shock because of hemorrhage. So he needs blood. What else does he need?
Oh.
What's that?
No, I'm just kidding, but a liver.
Oh no, he needs to go to surgery.
Delivered. Yeah, he needs whatever taken out or
Yep.
transplanted.
Right. He needs to stop the bleeding, right? So he needs to go to the OR. So just again, always kind of thinking of the root causes and what does this patient need ultimately. We could sit here and play around with him for a long time trying to get things right, but if we don't ever stop the bleeding, then we're never going to get anywhere, right? So what do you think so he's hypovolemic shock. So what is his CVP going to be?
Low.
Low. What about his SVR?
High.
High. Vasoconstricted. What is his cardiac output going to be?
Low as well.
Probably low. Yeah. If he's losing that much blood, doesn't have anything to pump out, right? Again, he's going to be trying to compensate, but if there's no fluid in the tank, it's going to be low. All right. So, by the way, he's also having trouble breathing and has unilateral chest rise. So in addition to the hypovolemic shock, what else is potential here?
Probably got a
More
hemo.
hemothorax.
Right, hemothorax, and that's going to cause hemodynamic issues as well as lung issues, breathing issues. So what does he need? What are you going to do for him?
Either decompress him or have somebody put in the chest tube.
Yep, exactly. So this guy, I mean, this is the classic trauma. Honestly, I'd probably bilateral decompress him. Obviously you're going to decompress the side that is most effective. But this guy's got so much trauma, bilateral, and definitely, you can needle decompress him and then put in chest tubes or just go straight to chest tubes, but he needs to be decompressed for sure. So his chest tube, they put in a chest tube and immediately gets 500 mLs of bright red blood. All right. And now his heart rate's up to 120. His BP is 50 over Doppler and respiration is 32. So, what now?
Bring in the chaplain.
Exactly, yeah. This might be a guy that they would, if you're not in a trauma center where the OR is right there, they might open up his chest right in the trauma room, You also, that bright red blood that comes out of his chest tube, you can actually transfuse that blood. So you guys seen on the chest tubes, they have some of the chest tubes have the pigtail. That's what that's for. There's actually a device that you can put on there and basically sucks the blood out of the chest tube, and then you can hang it up, spike it, and give it back to the patient. So it's called auto transfusion. So this guy probably, that's what I would be doing with him, giving him that blood. He definitely needs it, but also be trying to get, whether it's opening up the chest or whether it's getting him into the OR. That's what he needs. He needs that done. So he goes to the OR. He gets a repair of his liver. They're able to stop the bleeding there. They repair his lung laceration. And also they find out he was bleeding from his spleen. So they take his spleen out. He comes up to the SICU now. He's on the vent. He's sedated. He's not on any current drips, but here's what his vital signs are. Heart rate of 110, blood pressure 90/50, respirations of 20, CVP of 6, SVR of 40, or a stroke volume of 40, SVR of 2000, and a cardiac output of 5. So what do we still need to treat with him? What's still, anything is still
You
abnormal?
guys have a call?
His SVR is really high.
Yeah, so his SVR, so he's still super clamped down, right? And with that clamp down, he's getting a blood pressure of 90/50, still a little tachycardic. So what do you think you might want to do with him to treat that? Does he still probably need? He bled a lot. So what do you think?
He probably needs blood or fluid.
Yeah, so just like that person at the beginning that was coming from cardiac surgery, this guy probably still needs to be resuscitated. So typically, you get the acute resuscitation in the trauma room and in the OR, but typically you sort of need a secondary resuscitation to really get them truly back where they need to be. So he probably needs more blood, definitely needs more volume. All right, that's it. Any questions or thoughts? That's a lot of information, so.
No, I thought this was a pretty good presentation.
Well, thanks, Eric. Well, thank you guys for your
Yeah,
participation.
no. Thank you for doing this. This is great. Thank you, Sean.
Awesome. Yeah, you're welcome.
Thank you, Sean.
Yep.
Thank you, Sean.
All right, guys. Take care.
All right, you too. Bye-bye.
Bye.